Yeah. The screen is visible to all of you?
Yes.
Okay. Okay, so what is ADHD? A brief thing, what we know about ADHD as a layman and what we understand about ADHD. So ADHD basically stands for attention deficit hyperactivity disorder. And it's basically a condition which basically makes the brain difficult for the children to inhibit their spontaneous responses, which includes everything from movement to speech to attentiveness. So it's a very simple term which we can use, that yes, a child is not attentive or he's hyperactive in particular situations or in response to some situation where he should inhibit his control. In a very simple scenario, we might see that a child is going to an environment where he has to sit in a particular way in a social scenario where he cannot run here and there, but that means he has to control his inhibitions, he has to control his responses. So in such a situation, the child may not be able to control his emotions, and as a result he may show inattentiveness or hyperactivity. So this is a very common thing. All children during the lifespan at any particular age, especially during the preschools, the toddlers, or maybe just below the adolescence age, they might be feeling all these things. So this is nothing new, or this is nothing great which we can make, yes, a child is attention deficit hyperactive disorder. Because many of the children, because of the COVID situations, maybe because of pampering, because of the nuclear family, we might see the child is showing these things. But what is important to differentiate this common hyperactivity or tantrums from a true attention deficit hyperactive disorder is that it should not interfere with his routine social understanding, learning, academic activities. That means his day-to-day routine activities should not be affected. So if this is the scenario, then we can say, or we can think that yes, there might be something going different in my child. I will be taking up the questions at the end of the session. So there are some facts about ADHD. ADHD is one of the most common childhood neurodevelopmental disorders. And you will be amazed to know that according to the Indian statistics, 3 out of 5 every 100 children have some form of ADHD. There are different forms of ADHDs. And it does not vary from, it does not vary from socioeconomic status. It does not vary according to the races. It is more common in among the boys compared to girls. Now, just a word add on this. Autism is the fastest growing neurodevelopmental disorder. If I talk about autism, it is the fastest growing, but the most common is ADHD. So ADHD, what does ADHD means? Nowadays, we use the term neurodiversity or neurodivergent. Neurodivergent means it's not exactly a neurodevelopmental disorder, although in literature, in academic books, we do read about ADHD as a neurodevelopmental disorder. But nowadays, we are more fancy about going towards the term neurodivergent. Neurodivergent means it's basically a way of presenting, it's looking the world in a different way, in a different perspective. That means 90% of the children might be doing some work with the right hand. 10% of the children might be doing it with some other way, or maybe with the left hand. If I'm holding my ear like this, and 2% of the children are holding the ears with a turning head like this, that is also fine. But in social scenarios, in social settings, or in a true, social scenarios, it might not be acceptable. It might think, oh, he is something doing abnormal. So that is why rather than making a word of neurodevelopment, we are more now going towards the neurodiversity. So nowadays we talk about neurodiversity of the brain when we talk about ADHD and autism. So how does this ADHD look like? The two most important things are there, which we should always consider whenever we are working about ADHD: inattentiveness, hyperactivity, or impulsivity. So inattentiveness is one, hyperactive or impulsivity is another thing. So inattentive means, it's a very simple term. The term itself makes us understand inattentive means the child is not attentive. He might not be attentive in a class. He might not be able to concentrate on small things. He might be very lazy in completing those things. So he might forget, or he might not be able to write those things. He makes silly mistakes, although he might be knowing the concept, but he makes those silly mistakes because he's not inattentive. So just for the purpose of understanding, just forget the word ADHD. Just understand these meanings of these. So hyperactive. Hyperactive means the, now this is very, very important to understand a hyperactive child from an anxious child. Because whenever we use the terms hyperactive and anxious, although they are different, but when we talk about clinical picture presentation in a child, how does a child look? We many of the times we might confuse with anxiety and hyperactivity. So when we talk about hyperactivity means the child is fidgety. He's restless. For example, if you are going in a class, if you are going for the first time with a principal for a meet for the admission, so in a principal room, the child has to sit in a very concise environment, and he should be very polite. He should not fidget here and there. But an hyperactive child may not be an ADHD, but an hyperactive child might be fidgeting here and there. He might not be able to sit. So this is normal. This might be normal for one kid. This might be abnormal for another kid. But what is important is the child should not be hyperactive in situational settings. For example, he might be hyperactive in a particular scenario where there are so many kids are playing, so he also becomes hyperactive. They are doing mischief, I will also do mischief. But in an other setting, he is comfortable. So this is situational hyperactivity. So this does not qualify for a child for ADHD. So these things we should remember, that hyperactivity and attentiveness should not vary from situations. It should be present in every situation, whether it is situational or it is non-situational. Then you have impulsive. Impulsive means he's very quick. Whenever suppose we are asking something, the child may respond immediately without thinking. And it might be very difficult for him to wait for his turn, what we call as turn taking, like playing a carom board, playing a chess, playing ludo. So it becomes a very difficult for such children to control, to wait for their turns, because they cannot wait. They are very impulsive. So this is another thing which is where we look about ADHD when these parameters are present. Now, what is important is how will you differentiate between a normal behavior, that means a tantrum child, from a true ADHD? The thing which I told you most important is hyperactivity or impulsivity and attention should be present, but they should not be situational. They should keep changing from, they should not be situational. They should be present in every environment, whether it is a school, whether it is a home. It should not mean कि it's a nuclear family, घर पे सिर्फ mom and dad and grandparents है, तो grandparents have pampered the child, so he's very hyperactive there. But in the school, is a very calm child. We do not get any complaint. That does not qualify for a category of a true ADHD child. He might be tantrum, he might be showing a notorious child, but he's not an hyperactive child. So this is important things which we should always consider when diagnosing a child on ADHD spectrum. So normal behavior, again, how we can make, whenever this ADHD will look, it is generally present for a very young child. Usually it comes out before the age of 7. Another important thing, it should not vary from the environment and situations. As I've told you, it should be same in every situation. Another important thing which we always forget whenever we are making the diagnosis for ADHD is, we forget about whether this is hampering is understanding, whether it is hampering is learning, and whether it is affecting is academic skills or learning. Whenever it is affecting the hyperactivity, impulsivity to such an extent that whenever that it is affecting the relationships, it is affecting the understanding, academics, then it qualifies for a category of ADHD, that yes, the child might be going into the ADHD spectrum. Now, this is a diagram or the slide which I have shown you, that whenever a child is going into a state of hyperactivity inattention, we should not always think of ADHD. First and foremost thing is, ADHD diagnosis cannot be made generally before the age of 4 years. There are some, I would say some exceptions are there when we talk about complex ADHD, where the diagnosis can be made before the age of 4, but we'll talk it later. But generally speaking, the diagnosis of ADHD cannot be made before the age of 4 years. So when we talk about hyperactive inattentiveness, the things which we should always consider is whether the child is going to sensory issues, whether there are behavioral issues, whether there are medical issues, whether there are inattention issues. Why I'm telling you? Because ADHD isolation doesn't happen very common. The association with ADHD with autism and association of autism with ADHD is very, very high. It is around 30 to 60% association with autism with ADHD and 60 to 80% association with ADHD with autism. So the thing is, why I'm telling you is, whenever a child is diagnosed with ADHD, always think about whether the child is having some core features or some associated problems with autism, which is a comorbid condition or associated problem, because there will be sensory issues. Now, sensory issues are what we call about sensory processing disorder. We know that there are 9 different sensory systems are there: proprioceptive, tactile, vestibular, interoceptive. There is another important sensory system is interoceptive. That means the sense of internal sensation, whether how much food you should eat, how much you should eat, because various times we get a complaint the child was in the spectrum is वो बहुत ज्यादा खाना खाता रहता है, हर every time he starts eating food he doesn't know when to stop and suddenly vomits out. This is because her interoceptive skills are poor, not mature. He doesn't have that feeling that yes, my gut is full, I have to stop, so he keeps on eating again and again. So looking into a child, a 3 or 4-year-old child coming to you with very hyperactive, inattentive, always look out into other parameters, whether the child has sensory issues or not, whether the child is having auditory processing issues or not. It is a very important differential diagnosis is because when you are going in a mall, in a 4-year-old child is going to a mall, he might be immediately not be comfortable to loud sounds. He might be having auditory issues. He might do vocal stimming. So he might start screaming. So we might think that the child is doing, the child might be on an ADHD spectrum. The similar child, when he's at home, the mother is listening to a music, or there is some music is going on a TV. That music might not be comfortable to the child because of auditory processing issues. He may start doing vocal stimming. So we might think that hyperactivity is going in two situations. Is it the child is hyperactive or not? So before going to thinking that whether this is a true ADHD or not, rule out other things, whether it is a true auditory processing issues, whether the child is having behavioral issues. Now, what happens many a times, whether the child is on ADHD or autism, more talking about autism, they will always have social and language speech delays. So a 3-year-old child might be having a speech delay. He might not be able, his receptive skills or maybe expressive skills might not be that good. If he's having some problem in the stomach, if he's want food, अगर उसको खाना चाहिए या अगर उसको कुछ खाना है, he might not be able to express. So he might start showing what we call as attention seeking behavior, so that somebody comes and understands him what he wants and finally he might get that thing. Or he might be doing escape behavior. He don't want to do that task, so he starts shouting, screaming, attention, banging, running here and there because he wants to avoid that. Mother wants to teach him maths, but he wants to learn English. That might be tangible behavior. He is very tangible towards that particular thing. If you don't give me, I will start screaming, I will start shouting, screaming. Then you will start showing features of ADHD. So those associated problems should always be ruled out. Another important thing, medical issues. Adenoids is a very big problem in children with ADHD or autism, and because of that reason they might be having sleeping issues. uh, Said that, sleeping issues is also a big problem in children on spectrum and ADHD. So before going into the causes of chemical misimbalance of melatonin and serotonin, which is the cause for the sleeping issues, we should always rule out other factors. Adenoids तो नहीं है बच्चे को, टॉन्सिल्स की प्रॉब्लम तो नहीं है, क्या गट तो उसकी खराब नहीं है, कॉन्स्टिपेशन तो नहीं है, ब्लोटिंग तो नहीं है, यीस्ट इश्यूज तो नहीं है. So that is why it is recommended to yearly, annually have a regular checkup with your doctor for associated medical issues. So the purpose of this slide is, before labeling a child on ADHD, you should rule out these associated problems, and then accordingly we should categorize and then limit our diagnosis gradually, and gradually we should narrow it down. So pattern recognition between ADHD and autism is very, very important. See, whenever a child, as I've told you, the coincidence of autism with the association of autism with ADHD or ADHD with autism is very, very high. It is around, as I've told you, 30 to 80% it ranges. So many a times, because of the ASD features, we are underdiagnosing ADHD. Or sometimes when the ADHD component is high, we are not able to diagnose ASD. So that is why pattern recognition between ASD and ADHD is very, very important, so that we are able to make a clear diagnosis, whether the child is on the spectrum, whether the child is on autism spectrum, whether the child is on ADHD spectrum. So the most important thing is phenotype. Phenotypes means physical appearance, physical characteristics. The second most important thing is behavior patterns. How? So we will differentiate on the basis of these two things, which help us to recognize. First and foremost thing is just a brief slide about the autism traits. Now we always talk about autism core features. But these, I have made this slide in terms of strengths of autistic individuals. So these are basically the core features, but I have just renamed the slide. Instead of core features, strength of autistic individuals. Why I am using this strength, we'll be seeing that. See, autistic individuals, or I would say autistic kids, they are strong musical abilities. They have very strong interests. I would say they are very fussy. They are very, they are very fixed. They want to do that thing exactly that way. We use that one, repetitive stereotypical behavior, or they have typical fixations. So rather than using that fixations, I would say they are very meticulous in doing that work. So why we don't utilize that strength of those people, that they are very meticulous, they want to do that work very clearly and beautifully. Rather than using the wrong, the under strengths, we use the strengths of these individuals in motivating them. The another thing is they have very strong ability to follow patterns. So we can use their interest in particular areas, whether maybe in, in a particular interest like in drawing, or in particular interest like crafting, etc. and etc. So some of the another important thing is they are very good spatial learners. Spatial learners means they are strong visual learners, because they have a strong brain image mapping. They are able to understand visual. Understanding is much better than abstract learning. So when you are making them understand through images, they will learn very much faster compared to an abstract language. Then another important thing is, so rather than using the word deficits, we should use the word strengths. Then another thing is, what are the red flag signs of autism? Social communication. We know that they have a limited use of gestures. They have limited use of non-verbal communication. They are not able to understand the facial expressions of other. They are not able to understand, greet with others, how to greet, how to interact with others, because of issues with joint attention, eye contact, gestures, and etc. Then they have problems related to imitations. So these are some of the red flag signs of social communication, which indicate that yes, my child might be going into autism rather than going to ADHD. So social communication, we know that is just a revision slide. We know that yes, they have difficulty in understanding facial cues, verbal cues. Turn taking is a problem, and they are not able to understand what the person is telling, or what we can say, they have a difficulty in understanding receptive skills. No doubt, expressive speech delay is there, but along with that, they might be having a receptive speech delay also. So why there is a difficulty in social interaction with individuals on spectrum? The three most important thing is joint attention, eye contact, and imitation. Now, I have many of our parents or participants, they might have attended our webinars on social interaction or socialization skills in autism, where we have discussed in detail why this eye contact, joint attention, and imitations are most important in developing the socialization skills in children on spectrum. So this is the reason why social interaction is poor, because of these three factors. Repetitive behaviors. We know that they have a lot of repetitive interest. They might be flipping with hands. They might be rotating the wheels. They might be very much focused towards a particular thing. Either it may be a tape, it may be rods, it may be cable wires. They have very unusual interests. They may be playing with a spoon. They might be playing with the sticks. So those things. So those we call it as repetitive stereotypic behaviors, or what we use the term stimming. Now, why it is important, as I've told you, I have just given a revision slide on the important traits of autism, so that it becomes easier in our future slides to understand the difference between autism and ADHD. Why I'm telling this again? Because the co-occurrence of autism and ADHD is very high. And as a result, because of the dominance of one, the other thing might be masked. As a result, our approach might become difficult. We might be working on ADHD only, we might forget about the autism. We might be working on the autism only, we might forget about the ADHD component. So the treating ADHD with a comorbid can improve the outcomes of ASD intervention, and similarly it is vice versa. So if we are not able to treat both the components, the other component which is left untreated might increase the parental stress, might prolong the comorbidity in a child. So again, this is an important slide to understand that how the features of ASD and ADHD overlap. So many a times till now in the literature, we say that 75% of the children on spectrum have SPD. That is, sensory processing disorder. But now the latest research and reviews, now the stats have changed completely. Now they say that more than 90% of the individuals on ADHD and autism have sensory processing issues. So because of this reason, if you see the middle slide, it is consisting of most of the sensory processing issues, most of the sensory issues, plus executive functioning, plus other features of socialization, executive functioning, and sensory processing, and emotional regulation. So emotional regulation, executive functioning, and sensory processing, these three are important things which overlap between ADHD and autism. As a result, it becomes very difficult to differentiate between the two conditions when one of them is not very much dominant compared to the other. So as this is the stats which I have told you, that autism is the fastest growing developmental condition. It is around 2.8%, whereas ADHD is the most common. The prevalence is 5 to 11%. Now, again, in this slide, just observe the middle slide where I have mentioned you about the sensory issues, stimming, impulse behaviors, executive functioning, sensory issues, difficulty in eye contact, because these are some of the features which we generally see in autism, forgetting that these components are also present in ADHD. So if you see now, this is just a diagram which I have shown you how this ADHD and autism is overlapping. So 22 to 80% of the children autistic traits, they also meet the criteria for ADHD. So we can see that how much high is the percentage of autistic traits in an ADHD child, and they can meet the criteria of an ADHD. Similarly, children who are with ADHD, 30 to 60% have autistic traits. And another important thing is the neurobiology, means the genetic association, the genetic factors, the neurobiology of the brain, or the factors are almost coinciding, or it is almost the same. So the contributing genetic factors between the autism and ADHD responsible for them is almost the same. And another important thing is DSM-4, which has been replaced by DSM-5 in 2013. Till 2013, when we were using the criteria DSM-4, there was no associate. We were not able to diagnose autism and ADHD together. Either we would able to diagnose autism or ADHD, because the DSM-4 was such that we would not be able to combine both the diagnoses together. But now, because of DSM-5, we are able to combine all these diagnoses together. And this is the reason why nowadays we talk about co-occurrence and associated problems, especially with autism and ADHD, ADHD and autism. And because of the DSM-5, we are able to understand better and work together with autism and ADHD. So this is the overlap. So as I've told you that the overlap between ADHD and autism is relatively new. Why? Because till DSM-4, till 2013, we were not able to figure it out, that because the DSM criteria was such that. But now, because of that, we are able to work and we are able to make the diagnosis of ADHD and autism together. So the prevalence rate, as I have told you in the figures, it is very high, that autistic children also meet the diagnostic criteria in ADHD around 22 to 80%. And similarly, for 30 to 60% ADHD kids can meet the diagnostic criteria for autism. So talking broadly, it is almost 20 to 80% where we can the things of ADHD and autism overlap with each other. And as per the CDC, that is Center for Disease Control, 14% of ADHD children are also autistic. So this is as per the CDC, that 14%, the number is quite high. Now, this is another important slide to help us differentiate between whether the child is more of an ASD. We can't completely say that no, it is definitely ASD, it is definitely ADHD, because that is I would say that the chances is little low. Why? Because seeing the stats, seeing the prevalence of co-occurrence with ADHD and autism, it is I would say it is relatively not correct to say that it is totally definitely ASD, it is definitely ADHD. So that is why I'm using the term more likely to be an ASD, more likely to be an ADHD, which is less. That means it is an associated problem. The primary problem is which is more. So more likely to be an ASD means when we talk about social reciprocity. Social reciprocity means how the child behaves in a social setting, how he greets when an uncle comes, when some auntie comes, when he goes to a party, when he goes to a social gathering, when he goes to a movie theater, when he goes to a friends, how does he behave? How does he interact? How does he show his social engagement with others? That is what is called social reciprocity. Social reciprocity means that one once gives you an answer, how the child responds to that. So it is not one way, it is two way. And we know that it's a very big problem in children on ASD. So this picture will be inconsistent or poor when it is the child is going into an ASD. But in an ADHD child, the social reciprocity is absolutely fine. The problem is when the child becomes inattentive. This is the most important thing. And this is the thing where we forget, because many of the times he will be inattentive. And as a result, we might think he's not showing social reciprocity. So he's going into a more features of NASD, which becomes more common when a child is young. Then you have non-verbal communication. Now we know that children on spectrum, they have limited facial expression. They cannot tell my mom is angry. Mom might be giving a very hard facial look, angry look. He will not be able to understand. Mother might be get pain when hurting while doing something in the kitchen. She might get hurt with a knife. He will not be able to understand. He might start laughing. He might just ignore. The child might not be understand the pain emotions, what we call as an emotional dysregulation, or not able to understand the facial expression, whether the mom is angry, whether the father is angry. So these are some non-verbal communication cues which are lacking in ASD kids. They are typically present in an ADHD child. Eye contact. Eye contact is very good in an ADHD child unless and until when he's inattentive, fidgeting, roaming in the round. Whereas ASD kids will always have a poor eye contact. They may be fleeting here and there. They may be roaming here and there. They may not be able. And there are different theories why children on ASD do not show a good eye contact. We have studied all that. It is because of the reasons of high levels of excitatory neurotransmitters compared to the inhibitory transmitters like glutamate and GABA. So that is beyond our scope of discussion for today. But these are some of the important things which help us to differentiate between the two. Another thing is repetitive behaviors. They are typically present in ASD, what we call as stimming. Then peer interaction. Peer interaction again in ASD kids is very poor. The reason, the difference between the two is in both the cases, ADHD and ASD, peer interaction is poor. But the reason for interaction, poor peer interaction is different. That has to be understood, because that will help us to differentiate कि क्या बच्चा ये ASD का है या क्या ADHD में जा रहा है ज्यादा. Purely नहीं हो सकता कभी भी, whether it is more of an ADHD or whether it is more of an autism. So the thing when we talk, so difficulty with social understanding, turn taking. So they are not able to understand the social cues कि आपकी turn taking है या आपको आपकी turn है, आपको pretend play करना है. So this is poor in ASD kids. Whereas in ADHD kids, they are able to understand the social cues. They are able to understand what the person is telling, what the peer is telling, but they are not able to do that because their focus and attention is poor. Now, this is the screening tool which I have taken. Now, it's a very quick screening tool which can help us to differentiate whether the child is going to an autism spectrum or not. Why I'm using this? This is more of for the professionals to understand when a child comes to their clinic and when they are able to see whether it is more of an ADHD or an autism, or they are not able to figure it out. AQ10 is a very short and quick questionnaire which can give us a guide whether it is more towards an ASD or it is less towards an ASD. So it's a screening tool used between 4 to 11 years, can be easily downloaded, and it just consists of 10 questions, and even the parents can do. Now there are four categories: definitely agree, slightly disagrees, definitely agree. So accordingly the scores are given, and for only 0.1 is given. There is only one score, that is called 0.1 score. And 0.1 score, they have given this in scoring system. It's very simple. So any child who is having a score of more than 6 out of 10 might be going into a risk of autism. We also do MCHAT, but it is much quicker than MCHAT. So then we can think and can refer to an specialist for more further developmental assessment. Similarly, another ASD tool is for 11 to 15 years. So that we are using it for 4 to 11, and this scale we are using it for 11 to 15. Again, the same scoring. A score 6 or above should refer to a child for specialist opinion. It's a very simple scale. It's a very simple scoring system. You just have to use the scoring 1 as per the scoring system which they have mentioned. You can use score 1 for definitely agree and slightly agree for 1, 5, 8, and 10. For rest of the things, you need to work on the slightly disagree and definitely disagree. So this is they have mentioned. So it's a very quick, just takes 1 to 2 minutes to fill up this questionnaire. Even the parents, caregivers, and professionals can do it. So then coming to the DSM-5 diagnostic criteria. Uh, uh, till now, we have learned about the basics of ADHD, how we can differentiate from ADHD from an autism, what are the confusing factors which can make us confuse between whether it is an ADHD or whether it is an autistic. Now coming to the typical DSM-5 diagnostic criteria to put the child on the spectrum, ADHD spectrum, if he is there or not. So to meet the criteria for ADHD, there are basically 5 buckets of diagnostic criteria which must be fulfilled. That is from A to E. So A, B, C, D, E, 5. So there are 5 criteria which all should be filled. So criteria A is divided into 2, inattention and hyperactivity, which we already know that yes, अगर ADHD बच्चा है तो उसमें inattention और hyperactivity तो होगा. अब hyperactivity के साथ हम दूसरा भी यूज वर्ड कर सकते हैं impulsivity. So hyperactivity or impulsivity and inattention. Now within this inattention and hyperactivity, there are 6 different, I would 6 different symptoms are given. So in an inattention, there are 9 different symptoms are given. In hyperactivity also there are 9 different symptoms are given. मतलब inattention अगर बच्चा है तो उसके क्या क्या फीचर्स होंगे, उन्होंने DSM-5 वालों ने 9 क्राइटेरियाज दिए हैं, नॉट एक्जैक्टली क्राइटेरिया, सिम्टम्स. And if similarly for hyperactivity, so out of 9, 6 should be fulfilled to label a child or to diagnose a child in inattention or hyperactivity. अगर 9 में से 6 fulfill हो रहे हैं inattention के, then yes, he is in an inattention category. If it is being fulfilled 6 criteria of hyperactivity out of 9, yes, he is in hyperactivity. Now this is clear that whether it is an attention or hyperactivity. The other criteria which helps us to differentiate are also important. So first, going into the sub criteria of A1, inattentive type. So inattentive type, if you go into this chart, that is ADHD overview, signs of inattention, there are 9 different symptoms of inattentive type. That is difficulty with sustained attention, difficulty breaking down large projects into down. For example, अगर mother ने उसको बोला, you make this small, you cut down this paper into small 10 pieces. So this task requires attention. This task requires focus. He immediately loses that. He's not able to do that. Losing objects, where I have kept that. He's not inattentive. He forgets very easily. Forgetfulness. So requires sustained attention. A task which requires sustained attention, like threading, beading. So those things. So these are the different 9 criteria which has been mentioned. This has been directly taken from DSM. So out of these 9, 6 has to be fulfilled. Now the most important thing which we always forget is they have to be, these criteria should not be situational, as I have told you in my first slide. कि अगर वो डॉक्टर के केबिन में बैठा है या एक सेमिनार में बैठा है या एक किसी पार्टी में या किसी आई वुड से मीटिंग में बैठा है पेरेंट्स के साथ या पेरेंट्स टीचर मीटिंग में, जहां पे उसको शांति से बैठना चाहिए, अटेंटिव होना चाहिए, वो इधर उधर भाग रहा है, then it is an in that situation he is fulfilling 6 out of 9 criteria, but in home he is able to do all those things, then it is not an inattentive, because it has to be present in 2 or more situations. It can be school or home, it can be school or party, it can be friends party or home. So 2 important situations have to, 2 different scenarios or environments have to be taken. If it is fulfilling in 2 or more, then only inattentive is fulfilled. Similarly, another important thing is this inattentiveness should be severe enough to impact his learning, uski understanding, uske activities of daily living, what we call as ADLs, उसका academic learning, उसकी thinking, उसकी logical process. So अगर ये affect हो रहा है in a negative way, then yes, he is fulfilling the criteria of inattentiveness. Then we go into the, so inattention versus ADHD. It is very, very important, as I told you. What distinguishes ADHD from situational struggle is that it's a part of person's baseline and it is not on situation dependent. So that is what I was telling you. Simple inattention doesn't mean the child is going into an ADHD. It should not be situational. It should be irrespective of the situational conditions. The child should be inattentive. This is very, very important, which we often forget, especially even the professionals or even the parents. They might think, or even the I would say associated allied health professionals who are working with the children on spectrum or in ADHD, they might sometimes miss this thing. So ADHD criteria for A1 inattentiveness, as I mentioned. So these are the examples. So these are the 9 different examples which I have taken. So out of these 9, 6 should be fulfilled. Then only we will say that yes, child is going into the criteria of inattentiveness. So this is directly from the DSM which has been taken. These are the exact lines which we have taken, and out of these, he should be fulfilling 6. So then we come to the second criteria for A part, that is hyperactivity or impulsivity. So hyperactivity, these are again the 9 criteria which has been taken, as I've told you in the first slide, that for attentiveness and hyperactivity, there are 9 different criteria. Out of 9, 6 should be fulfilled. Often fidgets. So there is nothing to mug up, or there is nothing to, take a slide. It's just that the words itself makes us understand that yes, the child might be hyperactive, but you should remember the scenarios. So point number 1, if they often fidgets or tap hands on feet or spins and seat, where we want to sit simply, and the child keeps on banging. Now if he bangs this thing in, again in a scenario where he has to remain confined, and whereas in home watching TV is comfortable, then it doesn't fulfill the criteria of activity. But while in sitting at home, he's banging table, while sitting in a doctor's chamber, or sitting in some meeting, or in a parents teacher meeting, he's banging. So he's fulfilling the criteria in both the situations. So he might be fulfilling the criteria of impulsivity or hyperactivity. So often leave situations where remaining seated is expected. Many of the times children or ADHD mother teacher complaints, बच्चा टिकता नहीं है, बच्चा इधर से उधर भाग जाता है, बच्चों को तंग कर रहा है, पुश कर रहा है, इधर भाग रहा है. Now I'm using the word push कर रहा है. So that means he's pushing. He might be having an associated tactile issues. He might be an associated vestibular issues. Because of that, he might be running here and there. But hyperactivity might not be there because he's doing it only in situations in school. He might be getting a sensory overload because he might be having sensory issues. But the same thing he might not be doing in a home where he's alone, where he's comfortable. He's not getting sensory overload by that, information given by the teacher, so much shouting by the other school, bell ringing, sounds, and etc. and etc. So those things are always important to consider before making the diagnosis. So runs, climbs in situations. So these are different situations, always on a go, just like he's always want to run the bike, running here and there. So difficulty in sitting in one situation, restless, difficulty in waking, turn taking is a problem. So these situations should be present in more than two or more than 2 situations, and should be fulfilled. Out of 9, 6 should be fulfilled. Then ADHD subtypes, as I have discussed till now. ADHD inattentive type, that means more component is inattentive. Hyperactivity, impulsivity, that ADHD hyperactive. So we generally use the word sometimes inattentive dominant ADHD, hyperactive dominant ADHD, or predominantly hyperactive ADHD, or predominantly inactive ADHD, or combined, where he is showing both the features of inattentive and hyperactive. Combined means he is showing equal features of inattentiveness and equal features of ADHD, I mean hyperactivity. Then we use the word combined. But in children, the most common form is hyperactive ADHD. Combined and attentive is more in terms of, we go about adolescence age group and adults. But when we talk about pediatric age group, children's may, school age may, preschoolers may, hyperactive ADHD is the most common. So as I've told you, ADHD CNI are most common ADHD among adolescents and adults, whereas ADHD H is the most common subtype in preschoolers. So this is very, very important. Now, another important thing is, what we should remember is that a child, when he's going into his period of lifespan, from preschooler, schooler, early adolescence और बड़ा हुआ, जो ADHD का diagnosis है, वो during a period of time उसका change होता रहेगा. Why? जब बच्चा प्री स्कूल या स्कूल में था उसका हाइपर एक्टिव एडीएचडी डोमिनेंट होगा। जब वो एडोलेसेंस एज ग्रुप में जाएगा उसका इनअटेंटिव पार्ट भी आ जाएगा, और जब वो अडल्ट होगा उसका इनअटेंटिव एडीएचडी कंपोनेंट हाई होगा, प्रेडोमिनेंटली वो इनअटेंटिव बन जाएगा, क्योंकि जो हाइपर एक्टिव है that will be over a period of time he will get adapted. That is why we say that the major problem which comes is inattention in children who are adult ADHD. When they go from when they progress from his childhood to adult, the problem which comes is inattentiveness. Hyperactivity, they are able to adapt over a period of time with the environment and situation. That is why we use the word that in adults inattentive is more common compared to the children where hyperactivity ADHD is more common. Another important thing is जब प्री स्कूलर्स में जो इनअटेंटिव कंपोनेंट होता है कि ध्यान नहीं दे रहा, इधर उधर की छोटी छोटी चीजें में मिस्टेक्स कर देता है, अपनी स्पेलिंग उसको आती है लेकिन लिखते लिखते कुछ बी की जगह पी लिख देगा, दैट इज इनअटेंटिवनेस. व्हाई? बिकॉज व्हेन अ चाइल्ड इज इन द यंगर एज ग्रुप, दैट इज प्री स्कूलर एंड स्कूलर, उनमें इंटरनलाइजेशन फैक्टर्स बहुत होते हैं. इंटरनलाइजेशन फैक्टर्स मतलब जो हमने अभी डिस्कस किए, एसोसिएटेड बिहेवियरल इश्यूज, सेंसरी इश्यूज, एंजाइटी इश्यूज. सो ऑल दोस थिंग्स जो ये होती हैं, दे मास्क द इनअटेंटिव टाइप. मास्क मतलब उसको ढक देते हैं, इनअटेंटिवनेस को ढक देते हैं, और जो हाइपर एक्टिव पार्ट होता है वो डोमिनेंट हो जाता है. सो दैट इज व्हाई द थिंग व्हिच कम्स इन फ्रंट ऑफ अस इज predominantly ADHD, hyperactive ADHD in schoolers. So ADHD subtypes, just to summarize, is हमारे पास तीन होते हैं, इनअटेंटिव, हाइपरएक्टिव एंड कंबाइंड. इनअटेंटिव में हमारे इनअटेंटिव कंपोनेंट होने चाहिए, 6 में से 9 फुलफिल्ड होने चाहिए. अनदर टू इंपॉर्टेंट थिंग इज मोर देन 2 सिचुएशंस में होना चाहिए, सॉरी 2 और 1 और मोर देन 1 सिचुएशन, दैट मींस 2 और मोर. सिमिलरली हाइपरएक्टिव भी 2 और मोर सिचुएशंस, 9 में से 6 फुलफिल होने चाहिए, एंड दे शुड बी सिग्निफिकेंट इनफ टू अफेक्ट हिज लर्निंग. अदर इंपॉर्टेंट थिंग्स ये मैंने आपको बता ही दिया, दैट इट शुड नॉट बी इंपॉर्टेंट थिंग कि मोर देन 2 सिनेरियोज में होना चाहिए, उसके एकेडमिक लर्निंग इफेक्ट होनी चाहिए. अनदर थिंग इज जो हमारे पॉइंट ऑफ व्यू से नहीं ज्यादा इंपॉर्टेंट, इट इज मोर इंपॉर्टेंट फ्रॉम प्रोफेशनल पॉइंट ऑफ व्यू, बिकॉज देयर आर सम प्रोफेशनल्स आल्सो. सो द क्राइटेरिया ई इज मोर फॉर प्रोफेशनल पॉइंट ऑफ व्यू इज द hyperactivity inattentiveness should not be associated with any other associated problem. It may be personality disorder, it may be schizophrenia or substance abuse, and etc etc. So the cause of hyperactivity inattentiveness should not be explained by all those other causes, so it should be excluded. And generally in pediatric age group बच्चों में ये cause होते भी नहीं. So inattentive type, just a brief, it is more common, and attentive type is more associated with social anxiety. It is more common in adults, and that is why it is associated with more of internalization issues adults में, क्योंकि उनमें हाइपर एक्टिविटी ओवर अ पीरियड ऑफ टाइम कम हो जाती है. लेकिन बच्चों में जो इनअटेंटिव टाइप ऑफ एडीएचडी होता है जनरली गोज मिसडायग्नोस्ड, क्योंकि बच्चों में इनअटेंटिव टाइप नहीं पहचान पाते, क्योंकि एज आई हैव टोल्ड यू जो अदर एसोसिएटेड जिनको हम बोलते हैं इंटरनलाइजिंग डिसऑर्डर्स और इंटरनलाइजेशन इश्यूज या कंसर्न्स, व्हाटएवर यू यूज, कैन यूज द वर्ड सेंसरी इश्यूज, बिहेवियरल इश्यूज, एंड यू कैन से what you call anxiety issues, so वो inattentive feature को mask कर लेते हैं. So then we talk about ADHD comorbidities. Till now हमने autism के बारे में बात करें ADHD के साथ, and autism is also an associated comorbidity. Comorbidity means an associated problems. So ADHD के साथ बहुत सारी comorbidities हैं, sleeping problems हैं, autistic problems हैं, OCD की प्रॉब्लम्स हैं, ऑब्सेसिव कंपल्सिव है, टिक्स हैं, टॉरेट सिंड्रोम जिसको हम बोलते हैं, एंजाइटी इश्यूज हैं, इंटेलेक्चुअल डिसेबिलिटीज हैं, मूड स्विंग्स हैं, स्लीपिंग इश्यूज हैं. सो हाउ डू वी वर्क ऑन ऑल दिस थिंग्स, एंड व्हाट आर द एसोसिएशंस विद ऑल दिस थिंग्स? So when we talk about ADHD comorbidity, the first and foremost thing is trauma. अब it has been found that there is a strong association between post-traumatic stress disorder and ADHD child. So ADHD childs, the reason is I have seen a child, and he was basically we had a child around एक हमारे पास बच्चा था around 2 to 3 years back. So उसका dental extraction हुआ था, and he went into post-traumatic stress disorder. So because of that post-traumatic stress disorder, he was at the age of around 7 to 8 years. And during that period, before that, उसका ADHD component highlight ही नहीं हुआ. And when he went into that procedure of dental tooth extraction, उसको इतना ज्यादा वो पोस्ट ट्रॉमेटिक स्ट्रेस डिसऑर्डर हो गया उस चीज को देख के प्रोसेस को, that is ADHD component, more of an hyperactive component, it came into limelight at the age of 7 to 8 years. So this is an association of PTSD or post traumatic stress disorder with autism, with ADHD. And another important thing is they are more of victimization, in the sense they are more thrown out from the jobs because of the reasons of their hyperactivity and attentiveness. So just a take home message is that association with ADHD and trauma is much higher, PTSD much higher compared to autism. Then you have implications of ADHD and sleep. Now, sleep problems with autism and ADHD are much higher. Compared to autism, ADHDs have much higher sleep issues. And many a times we see that children who are on the spectrum, they also have sleep issues. Now, it doesn't mean that the child will not have a component of ADHD. It might be having a component of ADHD, definitely. But sleep issues, what are the reason of sleep issues in a child on spectrum and ADHD? The main reason is there is a misimbalance between melatonin and serotonin. And melatonin and serotonin, हमको पता है, these are two important hormones which play a very important role in regulating the sleep cycle. So because of that disturbance between the two, the sleep issues are very higher. And it is important to discuss about the sleep issues in ADHDs because अगर उनकी sleep concerns हैं, अगर उनकी sleep problems हैं, then definitely their hyperactivity and ADHD inattentive component in the school will not be improving at all. It's a very normal thing. If we are not taking a good sleep in the morning, we'll be an adult ADHD. We'll be behaving, we will not be able to properly execute our functions, we will not be able to pay attention, we will not be able to pay focus or attention on our tasks. So that means to say that sleep problems has a very high associated association with ADHD in improving the prognosis or deteriorating the prognosis. So whenever we are working with a child with ADHD, it is very important to take a detailed history and understand his sleep cycle. Because if we are able to regulate his sleep cycle, we might be able to improve his ADHD component a bit. So this is the Beer screening tool which we use for sleep evaluation. Beers itself is a mnemonic which tells bedtime problems, excessive daytime sleepiness, wakeful, regulation, and snoring. Now, why I'm using this sleep issues is because many a times this is used for children for 2 to 18 years. So that means the range is very high. It's very good for us to use this scale. Why I'm using, because many a times what happens, children with ADHD or autism, they have sleep issues and they are immediately being started on melatonin. No, we should always look into the sleep cycle, because sleep cycle might be affected due to so many reasons. The first reason is whether the child is taking the day nap or not. If a child is going for 3 hours of day nap, then how can you expect a child to go for a sleep at 9 o'clock unless and until you have fed up with them melatonin? Or then the problem is he will be going for a sleep in 1 a.m. in the night and will be waking up at 9. So automatically the circadian rhythm of the sleep is disturbed. When it is disturbed, automatically the ADHD component will be highlighted. Another thing is whether the child is having medical issues, whether he is having adenoids, tonsils तो नहीं है. The other important thing is gut issues. क्या उसके leaky gut issues ज़्यादा हैं, क्या उसको constipation है, क्या उसको bloating है, क्या उसको yeast issues हैं, whether he is on a intolerance to gluten and casein, whether he is taking a lot of high amount of gluten or casein. Another important thing is whether the child is having associated problems of sensory और रिसेप्टिव स्पीच लैंग्वेज इश्यूज, अंडरस्टैंडिंग कितनी है उसकी, रात में उसको पानी चाहिए या भूख लगी है, whether he is able to explain that, whether he is able to explain that thing, I am having this problem, I am having that problem, I don't want to sleep. So all those things, behavioral issues, sensory issues is again a very big problem though. They might be tactile issues. उसको ये बेडशीट का कलर पसंद नहीं है, उसको ये बेडशीट का टेक्सचर नहीं पसंद आ रहा. He is not very much comfortable with the temperature of the room. He is not very much comfortable with the darkness of the room. That light which is coming from the window, street light, is disturbing his visual. tactile, proprioceptive. There can be so many issues which can happen. So directly going on to the management of sleep issues with a medication is not the correct approach, not the rational approach. So whenever we are working on a child with ADHD, sleeping issues is a very big problem, not only with ADHD, with autism, because the association overlapping is very high. Whether it is autism, whether it is an ADHD, I never start on a melatonin on first sign. We always look into the cause of sleeping issues. We always look into the cause, and many a times, without giving a melatonin, you would be able to rectify the sleep causes if we are able to figure out the root cause for the sleep. So this is age group criteria and the screening tool which we have used for the sleeping issues. Then another ADHD has been found, the Tourette syndrome. Now Tourette is not, although tics are also another important thing which is very high in children on spectrum. And you can see that the ratio is 50 to 90% of the children with ADHD have tics. So tic disorder, Tourette, is another important thing, and which has been associated with ADHD. So we can see that how much is the association of comorbidities with ADHD. ADHD and autism. Now, ADHD and autism is one of the most common associations and overlap, which we have discussed in our previous slides also, that the reason why there is so much overlapping is the reason because they have so much overlapping of the genetic associations with each other. So the prevalence, I have told you, association is almost 20 to 80% with each other. Another important thing is anxiety. Now, anxiety is also a very big problem in children who are ADHD. Why I have told is this because over a period of time, anxiety is much more common in children than compared to adults. So at a period of time, we might be able to control anxiety, but it becomes difficult for a children under the age group or in the year age group of, peer age group, or I mean the school age group or preschool age group, to control his anxiety. As a result, the inattentive component जो होता है वो हमारा mask हो जाता है, as I have told you, and the hyperactive components becomes more and more. So anxiety is much higher in ADHD compared to any other associated problems. So different type of anxiety disorders are there, but we don't want to go into the detail. The important thing is anxiety is very much high in children on ADHD and autism spectrum compared to others. OCD, obsessive compulsive disorder. So OCD is again an important association with ADHDs. And another thing is OCD many a times gets misdiagnosed, or we are not able to diagnose ADHD as an associated with ADHD. That yes, OCD is there in children, and you will figure it out that 1 in 5 children on OCD also have ADHD, or you can make it vice versa. 1 in 5 children with ADHD will have OCD. It's more of a more symptom. So OCD is an association with ADHD rather than saying that ADHD is an association with OSD. So now coming to the biological aspect of coming to the causes of ADHD, why it happens. Till now we have discussed about the associated problems, the differences between ADHD, the diagnostic criteria of ADHD. Now coming into the causes of ADHD. What is the cause? What are the various things till now we have the literature has found and the research is told about the ADHD component, the biophysics. So I've divided into different biophysiological aspect and the impact on functioning, that is the executive functioning. So this is just a slide to show that what are the causes of ADHD. It can be genetic, it can be environmental causes, that is excess exposure to screen time, excess exposure to gadgets, especially in the COVID era, there has been so much gadget exposure. Now, one thing is very important is exposure to gadget doesn't cause ADHD, neither it causes autism. The only thing is that they can worsen the symptoms. This is very important to understand is because बहुत बार होता है कि सर बच्चा बहुत hyperactive हो गया कोविड के बाद, पहले वो नहीं था. Then you take a history, will get to know that 8 to 10 hours of screen time था. तो क्या hyperactive है तो क्या वो मतलब he becomes an ADHD? No, it is a virtual ADHD or a virtual autism trait. That means he is showing pictures suggestive of that autism, virtual. True autism nahi hai, it's a virtual autism. Because of the exposure to gadgets, exposure to the mobile screen time, you reduce the screen time, you reduce the gadget exposure, his interaction will increase, automatically his hyperactive behavior will settle down. So that doesn't mean that gadget exposure causes, it only worsens the symptoms. So going to the factors, there can be so many, they can be genetic causes, they can be environmental causes, या mother की history खराब थी, bad obstetric history था, during the delivery there might has been different complications, there might be different complications, or mother has not taken I would say vitamin D, iron, calcium supplements, or there is a bad obstetric history in the sense कि जब during the conception period or during that period the mother might having a lot of infections, he might be taking a lot of antibiotics. डिलीवरी होने के बाद इट कैन बी कॉजेज मैल न्यूट्रिशन, या बच्चा नर्सरी में बहुत टाइम तक रहा, या उसका न्यूट्रिशन अच्छा नहीं रहा, या ही हैज बीन एक्सपोज्ड टू लॉट ऑफ इन्फेक्शंस, या न्यूट्रिशन की कमी रही. So all those things. So the things are so many that we cannot figure out each and every cause. Important thing is we know that the child is an ADHD, we can manage that. But going to the causes doesn't make any sense because many times we are not able to figure out the cause. The important thing जो हमको remember है इस चीज पूरी स्लाइड में से एक important take home message ये है कि 12% चांस होता है रिकरेंस रिस्क का. अगर हमारा पहला बच्चा स्पेक्ट्रम ADHD है तो जो दूसरा बच्चा है उसका होने का चांस 12.5% होता है. अब ये सोच के हम ये नहीं कर सकते कि we cannot plan for a second child. It's just the figures. It doesn't mean that always the child will always land up into that. It's just a probability of going to a thing. As like I have told you that a child who is born by cesarean section, they have higher probability of going into the ASD spectrum rather than those who are delivered by vaginal delivery. क्यों? क्योंकि माइक्रोबायोटा, गट डिसमाइक्रोबायोटा हमने जो पढ़ा है अपने प्रीवियस वेबिनार्स में, गट डिसबायोसिस, इट्स ओनली थिंग इज कि गट डिसबायोसिस डिस्टर्ब हो जाता है अगर हम नॉर्मल डिलीवरी सिजेरियन करवाते हैं rather than going into a normal delivery. It only increases the chances of going to neurodevelopmental disorders. Probability doesn't cause it. So अब अगर हम इस बात में अगर हम जाते हैं इसमें जस्ट हमको इट्स गोइंग इनटू मोर ऑफ डिटेल कि ADHD का अगर हम MRI कराएं बच्चे का 99% वो नॉर्मल आएगा, क्योंकि रीजन ये है कि उसमें कोई लोकलाइज पैथोलॉजी नहीं होती या लोकलाइज कारण नहीं होता कि ये चीज में प्रॉब्लम है या ये चीज है या ये ब्लॉक्ड है या ऐसा ऐसा कुछ नहीं मिलेगा. द थिंग इज व्हाट वी विल फाइंड दैट इवन इफ वी गो फॉर द थिंग व्हाट द रिसर्च हैज फाउंड दैट देयर इज अ रिडक्शन इन कॉर्डेट एंड प्रीफ्रंटल कॉर्टेक्स. सो हमको एक मोटी भाषा में ये याद रखना है कि हमारा एक ब्रेन का पोर्शन होता है जिसको हम बोलते हैं PFC, प्रीफ्रंटल कॉर्टेक्स. इट इज द न्यूएस्ट पोर्शन एंड द मोस्ट हाईएस्ट डेवलप्ड पोर्शन ऑफ द ब्रेन कॉर्टेक्स में. उसका साइज कम होता है, उसका देयर इज अ रिडक्शन इन द साइज और रिडक्शन इन द थिकनेस. तो बिकॉज ऑफ दैट जो ADHD की प्रॉब्लम्स हैं वो सारी वो इससे रिलेटेड है. अब हम इस चीज में कुछ नहीं कर सकते. देयर इज नो मेडिकेशन कि हम इसको थिकनेस को ठीक कर दें, इसका रिडक्शन कम कर दें या इसके मेचराइजेशन को बढ़ा दें. नहीं, हम इसमें कुछ नहीं कर सकते. द ओनली थिंग इज इसके कारण जो प्रॉब्लम्स होती हैं, एग्जीक्यूटिव फंक्शनिंग, अंडरस्टैंडिंग, इनअटेंटिवनेस, हाइपर एक्टिविटी, हम उन पे काम करते हैं एंड ओवर अ पीरियड ऑफ टाइम बच्चा एनवायरनमेंट से अडेप्ट हो जाता है. If anyone says you I can treat that, it is not possible. We can only reduce the gap between the neurotypical and neurodiverse kids. Probably at the time of diagnosis the gap might be this one, but through the therapies, through the biomedical interventions, through the advice of others and through your efforts and through the efforts of the child, you can reduce the gap. But you say I will bring the child into a neurotypical spectrum, probably that might not be the case in every child, or it might be a case in 1 out of 100. But practically speaking, that will not be there. Always there will be some deficits will be there, but that deficits will not be significant enough to affect the independent living of the child. Our ultimate concern is to make the child independent at the end of our efforts. So अगर मैं थोड़ा और डिटेल में जाता हूं, you will find that जो ये हमारी ग्रोथ है, the blue line is the ADHD ब्रेन की ग्रोथ और प्रीफ्रंटल कॉर्टेक्स, और जो ग्रीन लाइन है वो हमारे टिपिकल ब्रेन, न्यूरोटिपिकल की. तो आप ये देखिए जो इसकी ग्रोथ हो रही है, जो इसका आई मीन से इसकी जो मैच्योरेशन हो रही है, मैच्योराइजेशन मतलब इसकी जो ग्रोथ हो रही है वो ADHD चाइल्ड में ज्यादा टाइम लेती है compared to an adult, compared to a normal typical. So this is the reason is it is characterized by delayed maturization, delayed growth of the prefrontal and the cortical areas or the prefrontal cortex. So उसकी growth delay है compared to a child on the spectrum, compared to a neurotypical child. जिसको हम एक चीज भी वर्ड यूज करते हैं साइनेप्टिक प्रूनिंग, जो हमने पहले भी काफी बार डिस्कस किया है. सो आई एम जस्ट कमिंग ऑन टू अ स्लाइड ऑफ साइनेप्टिक प्रूनिंग. साइनेप्टिक प्रूनिंग का मतलब क्या होता है कि जब बच्चा पैदा होता है उसके ब्रेन में बहुत सारे कनेक्शंस होते हैं, जिगजैग जिगजैग. मान लीजिए मैंने एक वायर, एक केबल वायर, 1 किलोमीटर की केबल वायर, उसको ऐसे ऐसे उलझा के रख दिया, ठीक है. अब उसमें से जब करंट फ्लो करेगा वो हर डायरेक्शन, हर हर एक एक जगह से जाएगा, फ्रॉम पॉइंट ए टू गोइंग टू पॉइंट बी. वो सारे कनेक्शंस जो भी उलझाए हैं, जो भी जिगजैग है, सब में से जाएगा. सो और एक मैंने केबल रख दी जहां पे उसकी मैंने लेंथ कट करके सिर्फ 50% कर दी, और वो इतने से कनेक्शंस में से सीधा ए टू बी जाएगा. सो आई वुड से जो एक 100 मीटर की वायर, मेरे पास एक 100 मीटर की वायर थी, वो डिस्टेंस फॉलो कर रही है इधर उधर उधर इधर से जाके फ्रॉम ए टू बी. और एक जो मेरी 50 मीटर की वायर है, 50 मीटर वायर, ही इज फॉलोइंग अ डिस्प्लेसमेंट, मतलब सीधा यूं जा रही है क्योंकि जिगजैग कनेक्शंस खत्म कर दिए. सो ऑब्वियसली किसका बेटर रिजल्ट्स आएंगे, व्हाट यू कैन से, किसके रिजल्ट्स बेटर आएंगे, 100 मीटर वायर के या 50 मीटर वायर के? कैन एनीबडी रिस्पॉन्ड मी, किसके रिजल्ट्स बेटर होंगे? You can speak, no problem, you can speak. Okay,
meters.
sorry.
50 meters.
50 मीटर्स एग्जैक्टली. सो जो 50 मीटर्स वाली वायर है उसके रिजल्ट्स बेटर होंगे क्योंकि उसकी एफिशिएंसी, उसकी पोटेंसी, उसकी लॉजिकल थिंकिंग बेटर होगी, बिकॉज ही इज फॉलोइंग अ डिस्प्लेसमेंट. सो इन अ सिंपल वे टू टेल कि जब बच्चा ग्रो कर रहा होता है फ्रॉम इन्फेंसी, चाइल्डहुड, एडोलेसेंस, अदर, तो जैसे जैसे बड़ा हो रहा है उसकी लॉजिकल थिंकिंग, उसकी एग्जीक्यूटिव फंक्शनिंग, उसकी प्लानिंग, उसकी जजमेंट, उसकी डिसीजन मेकिंग मींस इट शुड बी क्विक एंड फास्ट. सो दैट मींस उसकी एग्जीक्यूटिव फंक्शनिंग बहुत फास्ट और एप्रोप्रिएट काम करनी चाहिए. सो दैट मींस ही शुड फॉलो अ डिस्प्लेसमेंट rather than following zigzag path. जितनी देर में वो ऐसे ऐसे सोचेगा इतनी देर में तो उसका कुल काम भी खत्म कर देगा. सो दैट इज व्हाट वी से कि इसकी एग्जीक्यूटिव फंक्शनिंग पुअर है, ये तो बहुत जल्दी कर लेता है, समझता कम है. दिस इज एग्जैक्टली, दिस इज द कॉन्सेप्ट ऑफ साइनेप्टिक प्रूनिंग. सो दिस साइनेप्टिक प्रूनिंग मींस जो अनवांटेड जिगजैग कनेक्शंस हैं उसको कट करके मैं डिस्प्लेसमेंट बना दूं. So this is what we call synaptic pruning. So जब बच्चा पैदा होता है, न्यूबॉर्न बेबी, उसके पास बहुत सारे अनवांटेड कनेक्शंस होते हैं, इसलिए वो इतनी जल्दी थोड़ी काम कर सकता है जो एक अडल्ट या जो एक 10 साल का बच्चा काम कर सकता है. बट बाय द टाइम द चाइल्ड रीचेस टू द एज ऑफ 6 years or 7 years, the process of synaptic pruning already is completed 80%, and it starts by the age of 3 to 4 years or around 2 to 3 years, and it gets completed by 6 to 7 years, but it continues till the period of adolescence. ये नहीं है कि खत्म हो गया, 80% 6 साल पे खत्म होता है, एडोलेसेंस में वो कंप्लीटली खत्म हो जाता है. सो इसका मतलब ये हुआ कि अनवांटेड कनेक्शंस जो हैं मेरे बेटर बेटर इंप्रूव होते रहते हैं. अब जो ये अनवांटेड कनेक्शंस हैं, ये जो ऑटिज्म में होते हैं, साइनेप्टिक प्रूनिंग होती ही नहीं है. साइनेप्टिक प्रूनिंग मैंने आपको बताया कि अनवांटेड कनेक्शंस कट हो जाने चाहिए, लॉजिकल थिंकिंग तभी बेटर होगी. ऑटिज्म में साइनेप्टिक प्रूनिंग होती ही नहीं है, मतलब जो अनवांटेड कनेक्शंस है वो वैसे ही पड़े रहते हैं. लेकिन जो एडीएचडी है वहां पे साइनेप्टिक प्रूनिंग होती है लेकिन डिलेड होती है, मतलब जो 6 साल में होनी चाहिए वो 17 साल में होती है. दैट इज व्हाई we say that when a child, the ADHD children have a better prognosis compared to an autistic child जब वो adolescence में जाते हैं. Many of the times by the age of adolescence ADHD kids are able to adapt to the environment, लेकिन autism में problem होती है, वो नहीं कर पाते. You have to keep efforts, you have to keep working with the child. This is the concept of synaptic pruning, because synaptic pruning doesn't happen, it is under pruning, it doesn't happen, whereas in ADHD it is delayed synaptic pruning. So this is the diagram to make us understand that ये जो हमारे this in this slide I have shown you the last 2 slides. So ये synaptic pruning हमारी हो गई, यहाँ पे हमारे जो ये unwanted connections हैं ये नहीं हो पाए. So these are the things where synaptic pruning doesn't happen. In autism, in ADHD it happens, but it is delayed. So this is the diagram to make us little more understand. Now this synaptic pruning is the concept which is being taken from the concept of gut microbiota. That is what we call as microbial diversity, good and the bad bacteria. And this is very, very important when we talk about the diet, when we talk about the prebiotics, when we talk about the fecal microbiota. We have given a lot of webinars on this gut dysbiosis, how it is associated, what is the concept of that. but the ultimate thing is the latest research which now talks about is you need to keep your gut healthy in order to keep your brain healthy. There is a concept of gut brain axis, what we call as GBA. So this whole concept arises from the healthy gut or the gut dysbiosis. Gut dysbiosis is the major culprit which is causing all those things. You know, have we ever thought कि बच्चा 2 साल पे ही autistic के features क्यों आते हैं? Autistic traits are formed well before the child is born. जब बच्चा मदर वूम में होता है, ऑटिस्टिक ट्रेट्स वहीं से आने शुरू हो जाते हैं, क्योंकि हमारे गट माइक्रोबायोटा, हमारे साइनेप्टिक प्रोसेसेस सारे गड़बड़ होने शुरू हो जाते हैं. बट बाय द चाइल्ड जनरली व्हाट हैपेंस, जब बच्चा 2 या 3 साल का होता है, हम देखते हैं ही इज नॉट टॉकिंग, वो बोल नहीं रहा, वो दूसरे बच्चों के अगेंस्ट नहीं बोल रहा. देन वी गो फॉर अ प्रोफेशनल गाइडेंस, देन वी सी द चाइल्ड इज इन द स्पेक्ट्रम. We have never thought what is this ASD, what is this autism. We just thought कि बच्चा बोल नहीं रहा, over a period of time बोल लेगा, as many of our advisors give us this advice. But when we go up to age of 4 years, वो नहीं बोल पाता, and then we are shocked to see what is this thing. So why this problem कि 2 साल तक तो बच्चा ठीक होता है, हमको कभी कुछ लगा ही नहीं, 2 साल के बाद सडनली वो क्यों चला जाता है एकदम स्पीच डिले ऑन वो, बिकॉज 2 साल तक तो आपकी साइनेप्टिक, 2 साल तक तो आपके अनवांटेड कनेक्शंस रहते हैं, तो बच्चा नहीं भी बोल रहा, क्या फर्क पड़ रहा है, क्योंकि वो तो साइनेप्टिक प्रूनिंग हो ही नहीं. जब साइनेप्टिक प्रूनिंग होनी चाहिए थी, वहां उसकी हो नहीं रही है. तो जिसकी हो गई न्यूरोटिपिकल की, वो तो बोलना शुरू कर गया, उसकी एग्जीक्यूटिव फंक्शनिंग बेटर हो रही है, अब ये बच्चा लैग कर गया. So this is the reason why the presentation of autism traits generally appears by the age of 2 to 3 years. It doesn't mean that कभी पहले नहीं होती है in rare cases, but majority of the times autism do happen by the age of 2 to 3 years. And there is a myth कि 18 महीने या 2 साल की वैक्सीन लगी एमएमआर की, उसके बाद इसको ऑटिज्म हो गया. नहीं, that is not the concept. The concept is synaptic pruning ही 2 से 3 साल के बीच में होनी शुरू होती है, वहां उस बच्चे की नहीं हुई, इसलिए उसको ऑटिज्म के ट्रेट्स आते हैं, इसलिए नहीं कि एमएमआर की वैक्सीन लगी है. So there is no concept of MMR, there is no concept of this vaccine association autism. So now coming to our ADHD impact on functioning, हमारी executive functioning के synaptic pruning के कारण कैसे effect होती है. So when we talk about executive functioning तो बहुत common term है. Executive functioning का मतलब क्या है कि हमारे इसके 7 components होते हैं executive functioning के. Executive functioning सिंपल सी बात, मेरी थॉट प्रोसेस, मेरा मैनेजमेंट स्किल्स, मेरी जजमेंट, मेरी अंडरस्टैंडिंग, मेरा डिसीजन टेकिंग, क्विक डिसीजंस, यस और नो. अब ये सारी चीजें जो होती हैं, कहने में तो बड़ी आसान है, बट इट टेक्स अ होल पाथवे ऑफ 7 स्किल्स. सेल्फ अवेयरनेस, बच्चों को एक अवेयरनेस होनी चाहिए अपनी. सेल्फ अवेयरनेस इज सच अ स्मॉल थिंग, इट इज अ वेरी बिग थिंग इन चिल्ड्रन हु आर ऑन द स्पेक्ट्रम. सेल्फ अवेयरनेस सिखाते सिखाते 4 साल 5 साल निकल जाते हैं पेरेंट्स के, प्रोफेशनल्स के, उन बच्चों को नहीं आ पाती. सो जब पहला ही स्टेप गड़बड़ हो गया, तो अब कहां से सोचोगे एग्जीक्यूटिव फंक्शनिंग की. हम बच्चे को बोलते हैं इसको प्लानिंग नहीं आती, अर्थमेटिक नहीं कर सकता, ये नहीं कर सकता. अरे पहला स्टेप सेल्फ अवेयरनेस का आता है उसको. Is he able to understand his awareness where I am standing, where I am? So we need to work on the fundamentals rather than achieving big things. We are working on targets. We are not working on goals. We need to work on goals rather than working on targets. There are 2 kids of 7 years and one is in spectrum, one is neurotypical. कुछ 7 साल के बच्चों को 1 से 100 तक काउंटिंग या 1 से 1000 तक काउंटिंग आती है, मेरे बच्चे को नहीं आती. हमारा रहता है यार उसको आ रही है, मैं इसको सिखाऊं, उसको रटवा भी दिया. But when you tell him, okay, pick 2 pencils out of 3, he is not able to do that because he has just mug up that. He doesn't know the concept what does 2 means. So that is what we want to train. And we are not able to train that because we are working towards targets rather than working on goals. So self-awareness. Non-verbal memory thinking is also a big problem. Memory सिखाना भी एक बहुत बड़ी प्रॉब्लम होती है चिल्ड्रन को. सेल्फ मोटिवेशन ही नहीं है. उसको बोलेंगे कि बेटा वो एरोप्लेन जा रहा है, तो वो देख लेगा, बट खुद से कभी कुछ नहीं बोलता. खुद से नहीं बोलेगा मम्मा खाना दे दो, खुद से नहीं बोलेगा मम्मा मुझे प्यास लगी है. मम्मा ही लाके पानी रख देगी, प्यास लगी है, हाँ मम्मा प्यास लगी है. खाना खाना है, हाँ खाना खाना है. सेल्फ मोटिवेशन इज नॉट देयर. सो दिस इज अगेन अ बिग प्रॉब्लम. दैट इज बाय टर्म द कॉन्सेप्ट बिहाइंड दिस व्हाट इज कॉल्ड एज द मोटिवेशनल थ्योरी. So why the socialization skills is lacking? It is because of lack of motivation, and it comes by the word motivational theory. Emotional self dysregulation. इमोशनल सेल्फ डिसरेगुलेशन, देयर इज अ डिसरेगुलेशन ऑफ इमोशंस. हमको ये पता है कि एक बच्चा टैंट्रम्स थ्रो कर रहा है, उसको चॉकलेट दे दी, चुप हो गया. लेकिन ये स्पेक्ट्रम एडीएचडी का बच्चा है जिसको रो रहा है, चॉकलेट दे भी दी, फिर भी रोए जा रहा है, क्योंकि नाउ इज गॉन इनटू अ स्टेट ऑफ व्हाट वी कॉल एज आई वुड से इमोशनल डिसरेगुलेशन की स्टेट में जा चुका है वो, और ही हैज गॉन इन अ स्टेट ऑफ कंप्लीट लॉकडाउन की अब वो ही कैन नॉट रिटर्न बैक. So this is very, very important, or what we call as a sensory overload. देन वर्बल मेमोरी थिंकिंग, प्लानिंग प्रॉब्लम सॉल्विंग. सो प्लानिंग प्रॉब्लम सॉल्विंग तो बहुत बात की बात है, उससे पहले हमारे जो 5-6 स्टेप्स हैं ये हम ही नहीं कर पाते. सो दैट इज व्हाई वी आर नॉट एबल टू वर्क ऑन द एग्जीक्यूटिव फंक्शनिंग. सो दीज आर वेरी 7 इंपॉर्टेंट स्टेप्स वी नीड टू बी वर्कड ऑन before we think that my child is doing good on an executive functioning. Because executive functioning, if we see the funnel of socialization skills, सबसे पहले आता है हमारा sensory, हमारे सेंसरी इश्यूज, फिर हमारा आता है जॉइंट अटेंशन, फिर हमारा आता है सेल्फ अवेयरनेस, फिर हमारा आता है सोशल अवेयरनेस, देन वी थिंक अबाउट एग्जीक्यूटिव फंक्शनिंग. तो हम नीचे की 4-5 पिलर्स भूल जाते हैं, हम सीधा एग्जीक्यूटिव फंक्शनिंग में जाना चाहते हैं. दैट इज नॉट पॉसिबल. Then executive functioning, this is just for the knowledge point of view, this has nothing to do with our management or a thing. Generally, when we work with a child on language issues, we work on what, when and where. Now what, when and where are basically connected to different portions of the brain. हमारे ब्रेन में what circuit होता है जिसको हम बोलते हैं frontal और basal area से connect होता है. So ऐसे ही हमारे different circuits होते हैं why का. Now why generally what happens कि if you have been teaching or working with your child on language issues, you might feel कि what, when and where के questions they can answer better, but why is a problem. If you figure it out, the majority of the children will have problems with why questions when you are teaching them the concept of prepositions, when you are teaching them the concept of language, asking questions. What, when and where might be an easy task, but why is a problem. Why? Because when you're talking about why, it is the connection, the why circuit is the brain and the limbic system. So brain means the cortex and the limbic system is the connection. अब प्रॉब्लम क्या होती है कि ऑटिस्टिक चिल्ड्रन और जो एडीएचडी चिल्ड्रन होते हैं, और आई वुड यूज द वर्ड न्यूरोडाइवर्स किड्स, जो न्यूरोडाइवर्स किड्स होते हैं उनमें जो लिम्बिक सिस्टम होता है, लिम्बस मींस व्हिच इज कनेक्टेड विद द इमोशंस. हमारी बॉडी, हमारी ब्रेन में एक सिस्टम होता है जिसको हम बोलते हैं लिम्बस. हमको पता है बच्चों में इमोशनल डिसरेगुलेशन होता है, तो लिम्बस इज अ एरिया ऑफ द ब्रेन व्हिच इज कनेक्टेड विद इमोशंस. मेरी थॉट्स, मेरी फीलिंग्स, मैं कैसा सोच रहा हूँ, मेरा एंगर, मेरा एग्रेशन, मेरा बिहेवियर. अब एक सिंपल सा एग्जांपल इफ आई गिव यू, suppose a child is there and is showing lot of tantrums, he's screaming, he's shouting, he's showing all sorts of behavior, he's gone in a state of emotional meltdown. Kyun? Because he wanted that thing, tangible behavior is showing, but ultimately from the tangible behavior he goes into a state of sensory meltdown. And you gave him the chocolate. Now you gave him the chocolate because he was showing the tangible behavior. You gave him the chocolate. Now when you gave him the chocolate, what should be a behavior of a neurotypical child? Over a period of time he should settle, he should calm down, he will have his chocolate and he might go. But when a child but when a child on the spectrum, what will be the problem? He will be continue to remain in a state of meltdown. Why? Because जो हमारा connection होता है limbus is dominating our ब्रेन इन द ऑटिस्टिक चाइल्ड. हमारा जो कॉर्टेक्स होता है ये बोलता है कि चलो अब आप थोड़ा सेंसिबली काम करो, लिम्बस को बोलता है आप थोड़ा शांत हो जाओ और मुझे चॉकलेट मिल गई है, नाउ आई विल बिहेव इन अ सोशलाइज्ड वे. लेकिन हमारा जो न्यूरोडाइवर्स किड्स का वो लिम्बस सिस्टम डोमिनेट होता है, दैट मींस इमोशंस वाला. तो ये हमेशा अपनी स्टेट को डोमिनेट रखता है, और कॉर्टेक्स जो होता है जो बोलता है कि आपको बिहेव अच्छे से करना चाहिए, उसको दबा के रखता है. जस्ट लाइक दिस माय थंब फिस्ट, एक्चुअली इट शुड बी लाइक दिस कि लिम्बस नीचे रहना चाहिए और ये जो कॉर्टेक्स है ऊपर. लेकिन ऑटिस्टिक या न्यूरो डाइवर्स किड्स में ये ऐसे होता है, थंब बना के, ये डोमिनेंट होता है. तो उसके कारण क्या होता है, उसके इमोशंस ही उस पे हावी रहते हैं हमेशा. आई होप यू गॉट माय पॉइंट. सो दिस इज द रीजन why this frontal lobe and limbic system is a big problem, and that is why it's a more problematic in teaching why questions than teaching other questions. अब ये जो एग्जीक्यूटिव फंक्शनिंग है ये बच्चों में क्लिनिकली कैसे मिलती है, वही हमारे जो सारे फीचर्स हैं इनअटेंशन के, इधर उधर भागना है, सस्टेन नहीं है, छोटी छोटी चीजों में दिक्कत करना. क्यों? बिकॉज ऑल दिस प्लानिंग, एग्जीक्यूशन, किसको कितना कट करना है, ये काम मुझे इतने मिनट में खत्म करना है, मुझे कहीं जाना नहीं है, मुझे बहुत माइन्यूटली विद इन द स्पेस लिखना है, अच्छे से लिखना है, नीट एंड राइटिंग इज अ बिग प्रॉब्लम. Handwriting is a very, very big problem. No doubt, there are other issues of grip handwriting or proprioceptive issues. You can say motor issues are there, fine motor skills issues are there. But when you have worked on that, in spite of that, they might be having problems in writing. इधर उधर देखना. So what we call as कि इन बच्चों में problems आती हैं executive functioning की, because there's those different areas of the brain are not very matured enough. The connections are not good enough. इनको हम improve नहीं कर सकते through medicines. We can only make them adapt over a period of time. As I told you, we can reduce the connections, or we can reduce the gap between those, deficits. So natural history, this just to show that 90% of the individuals who are in ADHD will continue to struggle with the residual functional life. But this is just the stats. It doesn't mean that they will continue to struggle. The only thing is that rather than struggle, most of them will able to adapt with the environment over a period of time if a proper guidance and effort has been worked and with the child. So the most problem which happens is anxiety. Anxiety might be a big problem in children rather than in adults. So over a period of time, gradually their inattentive component will adapt over a period of time when they reach to an adult stage. But the problem is hyperactivity. Hyperactivity is a problem which remission means it can reappear. Majority of the time, hyperactivity is not a problem in adults, but if it is a major problem, it can always reappear back. Inattentiveness will not cause a major problem in adults, but hyperactivity, if it is there in adults, it can cause a major problem. So what is the impact of ADHD across the life? In school, preschools, I have told you behavioral issues. Adults, again in school and age group, behavioral and academic issues. That is why I have told you that these are associated problems which can happen along with ADHD. But it doesn't mean that these are the core features of ADHD. Why we are using these behavioral issues? Because it can be due to other issues also, like sensory issues. Can be, as I've told you, speech and language issues. So those things need to be tackled. And in the adult's age, those ADHD components, initially they might behave as in behavioral issues, but in adults, they might cause problems to their self-esteem. It can cause problems in employment. So that is why we need to work on ADHD gradually and starting from the beginning on those aspects over a period of time. But these stats gradually come down over a period of time when they reach to an adult. Why? Because they get adapt to the environment when they reach to that age. Their brain gets much better in executing the functioning than they were in the age of adolescence, because their hyperactive nature becomes less in adults and rather than their inattentive behavior. If the hyperactive behavior is more dominant in adults compared to the inattentive behavior, then it is a much more bigger problem rather than compared to an inattentive behavior of ADHD in adults. So now coming to how we can evaluate that, till now we have discussed about all these features of ADHD, comorbidities, and how we can now coming to the evaluation, how we can evaluate a child on ADHD. The most important thing is history taking. History taking, I have told you, हमको उसकी हिस्ट्री जाननी है कि उसके बिहेवियर्स कहाँ पे ज्यादा होते हैं, कितने इन्वायरमेंट में होते हैं, कौन से इन्वायरमेंट में होते हैं, या उसके मदर की हिस्ट्री क्या है. तो ऑल दोज थिंग्स आर वेरी वेरी इंपॉर्टेंट. घर में और कोई बच्चा है जो स्पेक्ट्रम में है, कभी पहले ऐसी चीजें हुई हैं, एसोसिएटेड प्रॉब्लम्स हैं. फिर एग्जामिनेशन rather than using the word examination, I would say observation. तो बच्चे को आपको ऑब्जर्व करना होता है. मेनी टाइम्स ये जो ऑटिज्म न्यूरो डाइवर्सिटी होती है, और ASD या ADHD, you can just observe some time with the child and you can make it out. Yes, there are some issues, no doubt. Definitely diagnostic tools are required, but these are not the only. These are the associated things which help you in making your diagnosis. Working directly on tools will not help you unless and until you have not seen the videos of the child or seen the child in person. Then it is difficult. So always take, and rather than viewing the child, because when you view the child, you might be seeing the child only for half an hour. If he is coming from 40 kilometers from his house to a doctor, he automatically will behave an ADHD child, though he might not be an ADHD child. So all these things need to be taken into consideration when you are working with and looking and observing the child, whether he has taken a good food, whether he has taken a night sleep, whether he is comfortable, whether he has well fed, all those things. So rather calling the patient to your clinic, I would suggest you to take multiple videos of the child from parents, because the child in his house will be in his a very comfortable environment. So whatever behavior he will show, that will be actually a true behavior rather than coming out of anxiety, frustration, and hunger. So that is why take multiple videos, observe the child, and then come to a conclusion and his observation that how he's behaving. Then after that, so examination, as I've told you. So observation, I have told you. Academics, you need to take detail as reading, writing, mathematics. So these are all assessment which you need to do. Then associated problems, anemia, thyroid. So these are not the major things. Important thing you need to figure out is sleeping disorders. क्या उसको sleeping issues हैं? If there are sleeping issues, take a detailed history which we have discussed initially. Because if we don't take a detailed history, yes, there are sleeping issues. You might be tempted to write a prescription of melatonin. So before doing that, take a detailed history whether he is taking a nap. If he is taking a very big daytime nap, you cut down the nap time of the day. Definitely his sleeping issues in the night will cut down. So those things are there, which is important in taking a detailed history and then figuring out the causes. So putting it all together is always look into the factors, what are causing that, rather than jumping on the diagnosis. What are the preceding factors? What are the associated problems? What are the strengths of the child? What are the family associated things? What are the factors or the burdens which are responsible for the particular things? So after doing this, so after taking a detailed history and everything, does the features suggest of inattentive and hyperactive? So till now we are doing the history only. So आपने history पूछी क्या वो घर में ऐसे रहता है या school में ऐसे रहता है, all those 6 to 9 parameters which we have discussed. So you get, and then you come to a conclusion, yes, कुछ picture इसकी inattentive और hyperactivity की है. Then you come to the thing, okay, you are getting this picture of inattentive and hyperactivity. Are there associated problems? क्या उसको sensory issues तो नहीं है? क्या वो बोल नहीं पाता इसी कारण तो उसकी hyperactivity नहीं है? क्या उसको gut issues तो नहीं है? So then you cut down to your diagnosis कि क्या क्या ये problems तो नहीं है, and accordingly you might feel that yes, these might be the associated problems which my child is having. Then you can use the tools. Now these are very simple tools and these are free of cost. The most commonly used is Vanderbilt School. This is used for 6 to 12 years. I have given you the link in red. You can take the snapshot, although the recordings will be available. So it is free of cost. You can just go onto this website and you can just click on, and you will be able to, there is a questions and you just need to figure it out online. You have to fill it. You will get the score immediately and you will get to know whether it is whether my child is landing in the ADHD or not. So these are easily available. They are free of cost. And Vanderbilt is the standardized scale. It is a diagnostic tool. And again, what we use is corner rating, but it is not free. You have to pay for that. But most commonly we use is Vanderbilt. So it is easily available and you can go through that. And those sometimes whenever if you want to use those scales, it can be easily administered. They are available in English also. So this is the scale. So this is the scale how we have to use this. So there will be just questions of never, occasionally, often, and very often. So you just have to respond them, and then you will get immediately will get the scoring of the child. So these are very simple tools and which will give a definite diagnosis. Then coming to on these things, then you look into the DSM-5. After all these things, as I've told you, yes, my child has symptoms of autism, inattentiveness. Another important thing, age group should be 12. The another thing which we forget is those 5 parameters. Are these symptoms present in 2 or more settings? सिर्फ वो घर में कर रहा है या सिर्फ स्कूल में कर रहा है, that is not the thing. It should be in more than 2 environments. क्या उसकी hyperactivity and attentiveness is to such that extent which is affecting his learning, which is affecting his functioning? If it is explains yes, then it could. Then does my child fit into a yes or no? If it fits, then yes, the child. Then you have to use, as I've told you, the Vanderbilt scales and the tools has to be used. Then identifying the coexisting conditions which we have discussed, all anxiety, autism, sleeping issues, gut issues, everything needs to be figured out. Then you look into the features of inattentiveness and hyperactivity, associated problems, whether these things are associated with other factors. Sensory issues hain, gut issues hain, all those things, speech delays hain, because those things have also been looked into consideration when you are making a diagnosis. 3 साल का बच्चा बहुत hyperactive है, irritable है, restless है, but he's not able to explain his things. So he's showing attention seeking behavior. You cannot label a child as an ADHD. So that is why is the importance of associated problems, which has to be figured out. Then coming to our slide, coming to the ends of a slide is simple ADHD versus complex. So we are not very much about the complex ADHD. Simple ADHD means the ADHD which generally presenting before, not presenting before the age of 4. Generally it presents between the age of 4 to 12 years, and there are no associated comorbidities like anxiety nahi hai, gut issue, OCD nahi hai, Tourette syndrome nahi hai. But generally, the presentation of simple ADHD is not very much there. Always there will be some associated problems of autism, the associated comorbidities of sleeping issues, associated comorbidities of anxiety. Definitely, they will be there. But generally, whenever we are making a diagnosis of ADHD, as I've told you, we cannot make a diagnosis before the age of 4 years. Generally, we should wait till the age of 4 years. The reasons is the child might not be, he might be a late bloomer, late talker. So because of that, his frustration might be coming out. He might be showing his behaviors in frustration, out of frustration. So that hyperactivity cannot be labeled as ADHD. So that is again a logical reason why we do not label a child as an ADHD before the age of 4 years, unless and until we are 100% sure, then it becomes a complex ADHD. So those are different things. So now just going through our presentation and everything, just our quick quiz to understand that how much we are able to understand about all these things. So this is a question. I'll just go through that and we'll spend some 2 to 3 minutes on this and see what we can figure it out on this. So parents complain to a doctor that their 3-year-old child is very mischief and naughty, doesn't want to sit at one place in the house, throws lots of tantrums if his demand is not met. He speaks only mama, papa. His receptive skills are good. He can do imitations and identification is fine as per parents. Presently, he can do scribbling. So he's a 3-year-old child. He can do scribbling only. Mother says he has frequent cough and cold with stuffy nose since the age of 1 year. Sleeping is a big issue. So sleeping is a big issue. He's hyperactive. He showed tantrums in the house. He has a speech delay. His imitations are good. His writing is delayed. He only do scribbling. He has a lot of stuffy and snuffy nose. Sleeping is a big problem. He has never taken a sound sleep. So sleeping is a major concern in this child. And academic wise, he's also lacking. So there are academic delays there in his child. The school teacher always complained that he doesn't pay attention in the class, always looking here and there. He cannot express his demands. So there is a speech delay. He cannot express his demand. Presently, he is not toilet trained, but recognizes all his family members and enjoys play with his sister. So presently, he is not toilet trained, but recognizes all his family members and enjoys play with his sister. So his social interaction is good. His identification, imitation is good, but there is a delay in speech. There are tantrums, and there is a complaint from the school teacher. There is a delay in speech. There is a delay in writing, and sleeping is a very big issue. There is a problem with stuffy nose. So, what do you think could be the thing in this child? Is he a late talker? Is he an expressive speech delay? Is there is a receptive or expressive speech delay? If there is a speech language delay, adenoid problems, behavioral problem, tantrums, or ADHD. So it's just see that whatever our opinions, the opinions can vary from person to person. So anybody who wants to speak on this? So can it be a late talker? Okay. So yeah. Anybody wants to speak? Anybody wants to share his thoughts?
If he is communicating through gestures, imitations, and if his needs are met, he may be late talker.
Okay. Okay.
But that is again, if he has a good eye contact, his imitation is good, and he's all pointing. If he has all that, he may be.
Okay. Okay. As in this question, his imitations are good. His social interaction is good. So
Yeah.
Okay, he could be a late talker. Okay.
He could be a late talker. Yeah.
Okay.
Again, I'm not sure about the receptive. I'm not able to get enough information on the receptive. How is his receptive? and
Okay.
expressive. Yeah. And there may be some health, like if he has a stuffy nose since from 1 year and a sleep problem
Mhm.
from long time, there may be some underlying issues too. Yeah.
Okay, so there could be adenoid hypertrophy. Adenoids means the enlargement of the tonsil in the nose. So it could
Yes.
be some
Yeah.
adenoids problem which can be causing this child. Because of that, there might be a delay in the speech, and because of that, he might not be taking a comfortable sleep. The positive things in this child is uh, the reason for his hyperactivity and disturbance sleep could be that he has a lot of stuffy nose, and the mother specifically complains that he is comfortable when they have taken him on a shoulder. So that is might be causing a lot of problem in this child. But is that the thing that is affecting his attention in the class? Could that be a reason also? It could be a reason. It could be a reason that it is affecting. It could be affecting his. But the positive things is his social interaction is good. He enjoys play with his sister. So one thing is very clear is that there are no. He might be temper tantrums. That is true. Tantrums is showing, but there are no features suggestive of autism. Or I would say there is no features which we can say there is a receptive and expressive speech delay. Because if there would have been a receptive, then his social interaction and interaction with the peers might not be good, because that requires a receptive speech. So that means his receptive and expressive speech delay is unlikely to be there in this child. Speech and language delay also, we don't think there is a speech delay, but language delay might not be a case in this child, because as I've told, he interacts well with his peers. He loves the company, as we have mentioned. So there is a difference between speech and language. When we talk about speech means verbal expression, whatever he's saying, but language means when he's talking speech and related to that particular context. For example, what did you have in dinner? I went to bathroom, I went to play store, I went to market. So he's having a good speech, but he's talking nonsense which is not related to the context. So that means there is a speech, there is not a speech there, there is a language delay. But when a
Uh,
child is having, but when a child is having a good interaction with others and peers, that will require a language.
but
So unlike,
here the child is interacting with his sister. They are not saying it with the peers, right?
yeah, child is
So
interacting with the system.
sister is again a family member, and interaction with the outsider, like with the peers or the friends, that comes as a social interaction, to be more precise. Like with the
Very good.
family member, they will certainly have some bonding. So
Yes,
in that
yes,
case,
that is
how will
true.
we say this is a social interaction?
We are just keeping our possibilities. We are just discussing and ruling out the things that could be a thing, that could not be a thing. But the thing what is mentioned here is he recognizes all his family members and enjoys play with his sister. So as
And
what you had,
he cannot
yeah,
express his demands.
yes, he cannot express his demand because his expressive speech is delay.
Yes, yes,
His expressive speech is delay. As he has mentioned, is his receptive skills are good. It is mentioned in the question, his receptive skills are
yes,
good. So receptive means
yes.
his understanding is good. So that is the thing. So now what the doctor advised is, doctor advised for an X-ray neck which was suggestive of large adenoid hypertrophy. So when the child was operated, and within 3 months after discharge, child's speech became better, his behavior settled, and sleep became sound. So this was a case of adenoid hypertrophy. So could it be a possibility? Yes or no?
Yeah,
It could be a possibility,
yeah.
because adenoids were to such an extent that it was disturbing his sleep so much. And adenoids definitely they can cause a lot of speech delay. It is very, very practical that a large adenoid hypertrophy then will definitely affect his academic learning, his sleep. Because if his sleep is disturbed, he will definitely shows his hyperactivity behaviors and all in the school. He will not be able to pay attention, and definitely his academics will lag down, because the sleep is a very big problem for this child. And because of all those things, definitely there'll be a delay in the speech. So the child got operated, and after that, over a period of 3 years, 3 months, his behavior settled, sleep sound, and as a result, he was also able to gain speech. His speech became better. So the purpose of this question is, at the beginning or at the look, it appears to be somewhat ADHD, somewhat neurodiverse kid. So that is why the purpose of this is to rule out each and every causes before we are going directly and jumping onto the diagnosis of a particular thing. So another question is, a 6-year-old male child with need-based speech, with average IQ, mother complains to doctor that he is always fidgeting in class, running, pushing, and disturbing other kids. He always screams as soon as he enters the school gate. This has increased over a period of time in school, and mother is worried. Mother says the child is cooperative with doing tasks at home, doesn't show such behaviors in home. What is least likely condition associated with the child? Least likely. ADHD, behavioral issues, auditory sensory issues, autism spectrum disorder. So all the problems which the mother is saying is he's very much fed up with his behavior in the school. There is a speech delay, IQ is average, fidgeting in the class, running, pushing, hitting, not hitting, disturbing others. You can say running or pushing, whatever, hitting. He's screaming in the school whenever he enters the school gate, and this behavior has increased over a period of time in the school. Mother is very worried. But on the contrary, mother says he's quite cooperative with doing tasks at home, doesn't show such behaviors in home. So what is this least likely condition associated with the child? So can anybody give his or her thoughts?
Can that be autism spectrum disorder?
Least likely?
Yeah.
Okay, autism spectrum disorder. Okay.
It is attention seeking, ADHD.
ADHD, least likely. Okay.
Least likely could be auditory sensory issues or the ADHD. And most likely it is autism spectrum disorder or the behavioral issue.
Okay. Why? Okay. Anybody?
Least likely is this autism spectrum disorder.
Okay. Why it is autism spectrum disorder least likely?
Because the child is cooperative at work. That means eye contact is there.
Okay. Okay. In my opinion, the least likely diagnosis is ADHD. Why it is ADHD? Again, when we did to the diagnosis of DSM-5 criteria, he is showing features of hyperactivity, he is showing features of impulsivity, or he is showing features of hyperactivity. Impulsivity is not very much clear in this, but he is definitely showing features of hyperactivity and inattentiveness, fidgeting, running, pushing. So he is showing features of inattentivity and hyperactivity. ADHD features is showing. But I have mentioned there, these features should not be situational. They should be present in more than one scenario, two or more. He is showing these behaviors only in the school. In the house, he is very much comfortable. He's cooperative with doing his task. He's not showing any such behaviors in home. So it could be situational that he's showing those behaviors in the school. So one thing is very clear, that he's showing this behavior only in one environment. As per the DSM and as per the criteria of ADHD, it should be in two or more than two. So it is situational. Now, why is showing the situational behavior in those situations? The first and foremost thing, he is running in the class, pushing, hitting, and disturbing others. So this hyperactive behavior might be because he is having behavioral issues. He might be a speech delay child because he is only need based. He might not be able to express each and everything to the teacher in the class. There is a class of 30 students. He wants to go to the toilet and he wants hungry. Somebody has pushed it. He is not able to understand how he will able to express. So he will show some sort of attention seeking behavior, might be so that he might gain attention from the teacher. It's very common in a child with a speech delay or need be speech delay. Other thing which might be happening is, we don't know, we are just figuring it out. Other thing which might be happening in child is, he might be having lot of sensory issues because vestibular. He might be taking lot of vestibular input by running here and there. Pushing might be tactile issues. Why does he scream whenever he enters the school gate? Whenever he enters the school gate, there might be a lot of kids, there might be ringing of bells, there might be entering of car horns, which might be disturbing him. It might be auditory insensitivity issues or auditory processing issues. So he might be doing vocal stimming instead of shout, which comes out as a behavior of shouting. He might get that sensory overload. It is specifically mentioned, he starts screaming always when he enters the school gate. So what is that thing which happens in the school gate? He might get sensory overload because so many kids are running, so many crowd is coming. He is need based. He might not be able to express. So he's showing all those behaviors. So all these things could be, it could be a part of auditory, it could be a behavioral, it could be autism. So these things are fitting. But ADHD component is not fitting, because if such behaviors would happen at the home also, then we would have thought of ADHD. So are you agree with me or not? That it could be least likely an ADHD component.
Agree, sir.
Yes. Yeah.
Okay. So to conclude about today's discussion, detailed history and examination are very, very important for the diagnosis of ADHD. Confirmation of DSM-5 and diagnostic tools are only helping tools. They are not the only tools. The important tools is our understanding, our observation, our history taking, and identifying between simple and complex, and then working on those associated problems. As such, we cannot do much about ADHD. We can work on the associated problems, so that over a period of time, we can narrow the gap between the neurotypical and neurotypical. So key of messages is ADHD is multifactorial, is common, and a multifactorial. Common means it is a most common neurodevelopmental disorder, even more common than autism. But autism is the fastest growing. Executive functioning are the challenges. We know that, and we face in reality with kids and with so many people. And environmental factors play a very important role, as we have discussed the role of gadgets, etc., peer interaction, or it could be, the COVID scenarios, which can give you a picture of virtual ADHD. So comorbid is a very, very big component which plays a lifelong role across the spectrum, across the lifespan of a person or a child. So we need to work on the comorbid conditions. So with this, I will end our today's workshop on ADHD, and then we'll be meeting tomorrow for ADHD 2. So I hope we had a healthy interaction with each of us, and we were able to take some information from today's workshop. So if there are any questions, we can take up for 5 to 10 minutes, and then we will wind up for today's session. And I would request, rather than putting up in the chat box, you can ask me directly.
Hello, I have a question.
Yeah.
Yeah, my son is 2.4 years old. He was diagnosed under AST in 18 months. And he's taking a ABA therapy, and from 18, it's been like 4-5 months, and he's gaining a lot of skills.
Okay.
And he is in a preschool now. He is in a daycare kind of a system with the ABA therapist.
Okay.
He is not interacting with the peers, but at home he plays with his brother. And he plays with me. He is very like, he plays peekaboo, he plays throwing a ball and all that. But in the school, he is not. He is tolerating the peers, but he is not playing, or he is not going to them. His language is developing. His receptive, both expressive, is developing. He is 2 to 3 word base. He communicates his need in 2 words. It was first only words before, then 2 words. His verbal imitation is very good. Like he quickly learns the things. And recently we meeting different doctors. They are like more likely saying he may be more towards ADHD. So we are really confused here. Is he really under ASD or ADHD? And the main problem we are seeing is inattentive. He is inattentive. Hyperactive. He is hyperactive. He cannot sit in a place. And his eye contact on his preferred topic, on his preferred activities, on his preferred, like if he is asking for food, water, or anything, on his needs, he is doing very wonderfully. But in certain case, when we hold him and we try to see his face, like when we ask him, look at us, he's struggling with both with us and with the therapist. He will not make the eye contact. It is, we can see that he's struggling to make the eye contact. But in a day, he gives us good eye contact, like when we are doing his preferred activities and those things. So here we are really confused, and he's learning the things. He's learning the things very quickly.
Okay. See, going through your history and going through the details of your child, Although in this 2 minutes, it's not very easy to comment,
Yeah,
but going
yeah,
through the little information which you have given me, the first and foremost thing is, one thing is clear, the child is having a speech delay or a language delay, though he's picking up over a period of time. But
yeah,
when you talk about the interaction with the peers, you know that
yeah,
nowadays the 3-year-old neurotypical child will be talking about, my father has bought me an iPad, he has bought me that, he has bought me that. They'll be talking so much much content, which our neurodiverse kids might not be able to tolerate, might not be able to understand. That means to say their communication skills will be so much fast when compared to a neurodiverse kid. So the first and foremost thing is, he might not be confident enough to talking to them. When he might be talking to a particular thing, he might be replying, the other person might be talking on a certain topic, they might be finished of that and they might be talking to that, or there might be a lag in conversation between the two. So he might not be confident enough to talk to them. He might be feeling low confidence in talking to them. He might feel, oh, what they might say, or they are talking something which is beyond his understanding. Now, if he's talking well with the child and home, there he's getting a sense of, comfortness. He's getting a sense of bonding. So there he can understand, yes, whatever I'm talking to my sister, she's able to understand, she's responding to me. So the first and foremost thing, what I will suggest you is, even if you are going to the school, you can have an interaction with the school teacher, that make his friends, not with the peer, make his friends who are elder to him, so that they can at least able to understand him. When he will be able, when he will be comfortable in talking to them, then he might be start talking to the peers. Whenever we are progressing towards the language in increasing the peer interaction, we always tell, first you increase the interaction with the parents, then you increase the interaction with the near relatives, then you increase the interaction with uncle and aunties or your relatives, or far relatives who are elder to the, who are basically elder to the child. Then you come to the children who are adult to him, then you start your peer interaction. So this is
mm,
how the hierarchy comes. Okay,
okay,
so yeah, so that is the thing. And now the other point of your thing is whether he is in the spectrum, whether it is an ADHD or that. See, 2.5, as I've told you, 2.9 years you have told me that, right?
2.4.
2.4. So at the age of 2.4, with a speech delay, with a poor eye contact, I won't tell right now he is a ADHD component or there is not, because there are speech issues. They might be, definitely sensory issues might also be there in the child. So I would also suggest you to do one sensory profiling. That might also be disturbing him, or that might be under noticed in a child. Okay.
Okay, okay.
Hi.
Yeah.
So
Yeah.
how does a neurodiverse kid adapt over time? Like, let's say he is presenting all those neurodiverse traits as a kid, let's say, who is 4 year old. So by the time he's, let's say, 16, or when he hits puberty or becomes an adolescent, so
Okay.
what is the likelihood that he will actually cope with the environment, or with his peers, or uh, you know um,
Yeah. I
get
got your point.
aligned with the
Okay.
social
I,
norms, you see.
I
So
got your point. Yeah.
yeah,
Okay. See,
that is my question.
there is a one famous quotation is there. Practice makes the man perfect. So similar thing holds good for here. If a child is being labeled, or if a child is being diagnosed with ADHD at the age of 4 years, this diagnosis will not continue lifelong unless and until we keep working on the child. It's not like a medical diagnosis. For example, a child is having a typhoid fever. He's diagnosed with typhoid fever. He'll be there. He will be diagnosed with typhoid fever till later also. The diagnosis will not change. But this is not the case in neurodiversity. If you keep working on the problems, if you keep working on the therapies, keep working on all those things which we have discussed, definitely over a period of time, he will come out from the severity of ADHD or maybe the component of ADHD. So all those things matter is in what direction you are following, in what guidance you are taking, and how much effort you are putting along with the professional, along with the child. So true. Now talking in terms of stats, majority of the children who are on the pure ADHD component, if and pure ADHD is generally rare, there might be some associated component of ASD definitely, but the ADHD component will have a better prognosis, and over a period of time, maybe around adolescence age group, he will be able to adapt to the environment. He will be able to adapt to the situations, provided his ASD spectrum part is not dominating it. If we forget about the ASD and just work on the ADHD component, then it can cause a problem. Because the problem which causes is the ASD component, not the ADHD component. So that is important thing is you need to work on the associated problems over a period of time, and over a period of time during the adolescence and the adult, the ADHD component will settle down over a period of time.
Does that apply to autism spectrum disorder as well? Let's say a kid has been diagnosed with mild autism at the age of, let's say, 2. So when he is reassessed at the age of 4 or 5, can it be a case like that? Like he's negative on the spectrum?
Definitely, it can be a case. See, if we suppose a child at the age of 2 or 3 years is diagnosed with mild autism, so we
Yes.
cannot keep the child as such. Oh, he's in the mild autism, nothing to worry much. Just over a period of time, he will settle down. The professional or the doctor or the concerned person who is working with it, they might say that yes, he's in the mild spectrum. Over a period of time, he will come out. But that doesn't mean we will have to keep the child as such. We will leave him as such. If we don't work with the child, if we don't put the efforts to the child, if we remain complacent, then definitely over a period of 1 year, we'll go from mild to moderate. And similarly, it lies if a child at the age of 2 to 3 years is diagnosed with moderate to severe. If you keep working with the child over a period of 1 to 2 years, from moderate to severe, he might come to a mild.
That's very helpful. Thank you so much.
Thank you.
So, a child having sense issues will have come under ADHD or ASD?
Ma'am, it can come into both.
Okay.
It can come into both. So with a sensory, we cannot label. Whether, see, the thing is not to label a child, because you can label a child for see, diagnosing ADHD, ASD or SPD is only for a documentation purpose, for your medical legal issues, for your school admissions and everything.
Okay.
The thing is, your approach has to be tailored as per the needs of the child. It cannot be a generalized approach for every child. And SPD can have in both, whether it is an autism, whether it is an ADHD, it depends upon the severity, depends upon the presentation, it depends upon the associated problems. Okay.
Actually, we cannot work on only one issue, right? We have to work on all issues. So we cannot find difference between ASD and ADHD.
That is what I'm telling. That is what I'm telling. The problems or the appearance is so much, overlapping that it becomes difficult.
Yes.
It becomes difficult.
Yes, sir.
What is the major treatment difference for ADHD and ASD? It is all the same therapies and same thing, or where we have to give more emphasis on certain therapies for ADHD? How is it? How do you differentiate the treatment plans?
See, that is what I'm telling. The most important thing is your approach depends. Whether if the component of ADHD is more, then you have to work more on the behavioral issues. We'll be discussing in this, management part. In our in this workshop too, we'll be discussing on this management part, because this question is more of a management part. So we'll be discussing in workshop 2, and after that we can take up these queries. It will become better after discussion with workshop 2. Okay.
Sure.
Okay. Thank you very much, participants, for today's workshop. Thank you for attending. Have a good day. Good night.
Thank you.
Thank you.
Thank you, sir.